So let's move on to our next speaker. Cristian Montenegro is an assistant professor at the School of Nursing at the Pontifical Catholic University of Chile and is a researcher at the Millennium Institute for Research on Depression and Personality. He is a health sociologist interested in mental health policy, and he has co-founded the Platform for Social Research on Mental Health in Latin America. During this conference, he will share with us his experiences with decolonizing global health education in the Global South and suggest ways to do so in the Global North. Please welcome Cristian.
Thank you, Aileen. It's good to see you after all the communications. Thanks everyone for participating in this. This is very exciting. I'm very glad to be able to share some thoughts and some experiences that me and some colleagues have developed here in Chile. I'm going to share my screen now. And also I'm gonna put my timer. Okay. All right, so the title of this presentation is why should we train people on global health when we still have so many public health problems here? And I think it kind of connects very nicely to the prior presentation by Mariam. On the challenges of teaching global health from the South. So, sorry. Well, for this presentation, of course, I'm relying on the wealth of discussions and proposals that can be organized around the idea of decolonizing global health. This is a kind of a discussion that is reaching a certain maturity, and this event is a symbol of that in a way. That means that I'm not starting from zero, and I'm not proposing any foundational concept or alternative definition. I'm accepting that we have a problem, and I think that we all share that consensus. That global health is filled with asymmetries and inequities, and that we need to address and transform that, and that academia is a key agent of this transformation. In more specific terms, I'm concerned, I mean, the more specific concern that has moved me over recent years are the local reverberations of these concerns that have gradually been subsumed under the notion of coloniality. My question is, and I don't really have an answer for this, but my question is, how do we as academics and researchers based in the Global South or in Global South institutions shape this discussion so that it has an effect on our locales, on our countries or the places that we work? Because although paradoxically, there is a risk that the discussion around decolonization only makes sense within the context of the global north, as an internal dispute or as the latest controversy, mobilizing positions, opening debates, and refreshing the field, because controversies have that ability. They do not only block or transform, they can sometimes, their only effect is to kind of refresh the field, refresh the arguments. And we don't want that to happen. We want this discussion to really have an effect. So with that in mind, I mean, that's the way I approach this discussion. With that in mind, I want to say that I don't want to base my arguments only on ideas or only on theory. Instead, I want to talk about an initiative directly linked to this problem. I'll start by talking about and supplementing some of the points that me and Marcela Gonzalez and Margarita Bernales, two colleagues, made in an editorial published last year in Critical Public Health. You can see the cover here. The editorial is called Teaching Global Health from the South, Challenges and Proposals. We wrote this before COVID, and as Mariam was saying, COVID represents a I mean, it seems to be a deep change, especially through the use of technologies and the ability to connect more people and to make it more easy for more people to participate in crucial debates and in also to participate in learning and teaching. So this kind of changes. So I want to supplement what we developed in this piece with some afterthoughts. And this was born out of a concrete challenge of designing global health courses, postgraduate and undergraduate courses at the School of Nursing of the Pontificia Universidad Católica de Chile. So this is, in a way, a testimony of the kind of questions that we had to address, the sense of, does this make any sense? Does it make sense to teach global health in the Global South? And before going into that, I would like to spend a little time talking about the relationship between universities and global health, which I think is a crucial aspect of the discussion that we want to have today. So the role of universities in the existence and continuity of what we call global health is key. More generally, I want to talk about how certain geographically circumscribed entities, like universities, are able to transcend their spatial constraints to develop an identity and a mode of observation that one could call global. The ability to take off from the limitations of proximity and the weight of being somewhere. One could ask, how can some institutions and their actions cut through the gravity of the local, to put it a name, to consider and to intervene in places very far away? I think we need to consider this because also for the idea of teaching global health from the South, this is an important aspect. So a number of conditions, in my view, are required if one wants to understand the ability of certain institutions to hold the power that they hold at the moment in the way global health is structured right now. So first, you need a legacy of historical domination or historical intervention, either through colonialism or through imperialism. And I talk about imperialism because in Latin America, imperialism is the direct continuity of colonialism. Imperialism understood not as kind of the administrative control of countries, but through a strong influence, through economy, through internal political intervention, etc. So you could say that is a more subtle, but it's not that subtle. It has concrete, really direct interventions. So you need to go back to my point, to create this ability to reach many places. You need a legacy of historical domination or intervention that creates an administrative or bureaucratic chains of command and control spanning the globe, producing a high degree of what I would like to call monodirectional extractivist connectivity between a few centers and many nodes around the world. So we need to understand that. This is the basis for the way certain universities have reached the degree of power that they have. At the same time, this legacy, this connectivity, produced an unprecedented accumulation of wealth. And with the development of science and clinical and public health interventions that together with other contextual elements produce what we call an epidemiological transition, a transition in those countries that creates a split between those diseases here and those diseases over there. Thanks to this split, flying above the ground to help those in those other countries seems both legitimate and inevitable, Considering the first legacy, I mean the existence of that intense connectivity. So we have two sort of historical conditions of possibility of the development of global health. Universities, especially through their push toward internationalization, play a key role in creating this anti-gravity. They do not just make use of such legacies and opportunities, but constantly invest and rely on the ability to take off, to observe and intervene at a distance. This attracts talent, resources, citations, influence, and prestige. After this, because of institutional mechanisms, global health initiatives or projects or departments will push for their own continuity and growth, achieving a degree of autonomy vis-a-vis the actual requirements and needs of those distant places. And this is something that we need to understand. So in 2009, a team of academics here in Chile met to consider the possibility of launching global health teaching contents in a place that does not really accomplish premise 1 or premise 2. That means a place that is mostly connected with dominant centers of power, but not to the periphery, not even within our neighbor, to put it in a way, not even within the region. That is in a country that still needs to deal with complex, widespread health problems internally. So this is the context. Precisely because our context was so different, is that we wanted to avoid simply copying the formulas around global health created elsewhere. How could we do differently? Creating a more close to the ground approach to global health. The key question that we faced was, what sort of knowledge about global health would make a difference at the local level? And conversely, how do we approach our own health problems and solutions in a way that could make a difference in distant places? To put it differently, how do we take part in current discussions about global health in a way that remains connected and relevant to local problems and solutions, a form of locally rooted global health education? This was the challenge. This was what we wanted, in a way. So I don't think we really have an answer, but we do have a vision of the challenges, a degree of clarity about that. And I do believe that somehow these challenges are also relevant for universities and research centers in the global north, or at certain points, in certain elements, that have an interest and an honest intention to decolonize their own practice. So of course, the first challenge is the hegemony of the English language. This is a complex issue because it's very intuitive. We know English is a problem and at the same time it's a solution. It's kind of a double-edged sword. I was discussing this with other colleagues and we said, okay, when I write in English, I'm also writing for people in Japan, people in Pakistan, people in Nepal. I'm not writing for the centers of power, I'm using the medium. But I think that is kind of a simplistic way out of the conundrum, but this is a conundrum. So the first challenge is the hegemony of the English language, since, as we know, most of the global health literature is written in English. Not only this, but most global health programs are offered in English, even in non-English speaking countries. This acts as a barrier for accessing for training, a barrier that goes beyond academia, with local health workers, policymakers, and government officials having limited opportunities to inform their practice with emerging or comparative evidence. Another closely related challenge is the biomedical predominance within the field, a tendency that informs global health. The perspectives of sociology, anthropology, historiography, or political science are key for understanding the role of local specificities on health and illness, and those perspectives are still marginal. If discrete metrics and forms of quantification purely based on biological phenomena are our only tools to make sense of the world, then the cultural, historical, and political conditions that shape disease will remain invisible. Power will remain invisible, including the forms of power that shape our own professional identities and our visions of what needs to be done in the field. But the third challenge, and probably the strongest challenge for us trying to do this from Chile, was this question: does it even make sense to teach global health in the South? And I want to stop in this question a little bit more. The most obvious and the most kind of difficult challenge that teaching global health from the South faces is to overcome the idea that it doesn't make sense to teach global health in the South. The idea that thinking and acting in global terms in relation to health and disease makes more sense in certain places like London or New York, and not in others like Lima or Accra. To recycle an old George Orwell's famous phrase in Animal Farm, all places are global, but some places seem more global than others. So how do we kind of deal with this? We've been faced with this question, asked directly by colleagues here in Chile. Why should we train people on global health when we still have so many public health problems here? Why not just public health? And I think it's an important question. And I've seen it kind of popping out in different events. And we need to take it seriously. Our first attempt to reply, and this was the this might be very specific to Chile and Latin America, is that we are already being the object of powerful global agendas. Agendas around trade deals, patents for medications, the manufacturing of essential medicines, etc. So our sovereignty is already limited. It's already framed by a global framework. We are subjected to global geopolitical determinations of health and disease at the local level. And therefore, we need to situate our local public health efforts carefully attending to global phenomena. But a further response comes after that. What we do locally can and should have an impact elsewhere. We should be able to share information and practices with other countries. We should be able to compare our situation and launch regional and South/South collaborative endeavors around health. Maybe we could conceptualize this by saying that in terms of health, disease, healthcare distribution and accessibility, places like Chile or Nigeria or Pakistan or Malaysia need to move from being objects of global health to become agents of global health. This transition from objects to agents should be the focus of global health training in such places and in the global South at large. And this is clearly a different global health, and I want to be very emphatic on this. This is a different global health from the one that we already know. A global health that has as its vision the movement from being subjects to being agents. This, in my view, should be the concern of the development of global health programs in the global South. But at the same time, I think that this has a lot of lessons to give to the institutions that are already and has historically developed international health and global health. Finally, as we argue in our 2020 piece, crafting a Southern view and practice of global health requires two analytical movements and an affirmative movement. So the analytical movement is to focus on local conditions and sociocultural foundations of health and illness, bringing local history center stage and drawing extensively on the social sciences. The other analytical movement reflexively considers the geopolitical imbalances that are at the core of the global health enterprise in order to undo them in the act of teaching and training. This double reflexive approach can aid students and academics to observe from an ethical point of view their professional practice, tracing the local and global dynamics at play in the emergence and distribution of health and disease, But at the same time, I think we need something more. We need something else, not just this critical, analytical approach, this sort of reaction to what global health is at the moment. And this is what I call the affirmative movement or the affirmative moment. We need a moment of affirmation whose scenario must be the global south. Self-affirmation, or the affirmation of our global role, of the power of our own practices, the value of our own ideas and intellectual traditions. Only this self-affirmation engenders reciprocity and dialogue. Thanks.